afternoon, everyone. And I, Dr. Ananya Prabhu, Chest Specialist at NITRD. I, along with my team members, Dr. Jyoti and Rakeshji from Share India, welcome you all to today's 111th session of e-NISCHIT. And today we have a very, very important topic which will be discussed today on one aspect of tuberculosis, dealing with the side effects and how to reintroduce the drugs. And for this, it's my proud privilege to welcome our expert for today, Dr. Puri sir, who's a senior chest physician and has over 4 decades of experience in tuberculosis, and not only in treating tuberculosis and identifying the challenges and dealing with all kinds of tuberculosis, including drug-resistant tuberculosis. He also has all the experiences in giving direction to the medical colleges and the DTOs and training DNB students at our college. So we couldn't have found a better expert for a topic like today, today. Thank you, sir, for joining us today. We welcome you. And we also have Dr. Rajesh. He's Chief Medical Officer with us at NITRD, and he's also Nodal Officer Training for our hospital. So he's well versed with the fact that in spite of all the resources and the facilities and the trainings available, what are the field challenges that tuberculosis still we have to face at the field level. So that's why we have invited him today, because the situation what we are dealing today is actually a clinical practical problem. Thank you, sir, for joining us. Thank you and our case presenter today is Dr. Archana Singh. She's a medical officer at ARTBHU. Thank you for sharing your case today, and thank you so much. And we welcome you to the initial session. We can start so you can start the screen sharing and we'll start the session.
Okay, ma'am, thank you. And the young male patient came to us on 9/22 as a diagnosed case of abdominal COX and was on ATT from a private hospital since 18/2/22. So we started his ART with TLD plus DTG as per the national guidelines along with CPT. His baseline CD4 was 39. On 17/3/22, he visited to us with complaint of diarrhea and hiccups. So we advised LFT and serum creatinine. Of which serum creatinine was absolutely normal, but LFT was deranged. SGPT was 434, SGOT was 432, and serum bilirubin was 5. So we stopped his 4-FDC and put him on modified ATT with injection streptomycin, tablet alsin, and combutol. After 1 week, he again came to us with complaint of hiccups. So we repeated LFT, which showed the raised serum bilirubin, but OT and PT were normal. After being symptomatic, after giving symptomatic treatment, we have added capsule arsine and tablet INH one by one, along with injection streptomycin, which was stopped on 26/4/22. And patient continued with tablet alsin and 3-FDC. After 1 month, we stopped alsin also, and ATT was continued with 3-FDC. His ATT was completed on 5/12/22, as his USG was absolutely normal and all the baseline investigations were within normal range, and his CD4 improved to 224 and viral load was less than 150 copies per ml. During this course, he gained 10 kg of weight and his adherence was 100%. So my question is, how to modify ATT in a stepwise manner when there is deranged LFT and RFT, and which drug should be added first, and for how long we have to continue alsin according to new tuberculosis guidelines. Thank you, sir.
I will request you go through, so we want to scroll through the investigations. So please show us let the audience see all the investigation as well.
When all the investigations are put in this screen and it's being shared, the initial on 19/3/22, his creatinine was 0.6, serum bilirubin was 5, OT was 432, PT was 434, and HBS AG and anti-SCV were non-reactive. 26/3/22, his bilirubin was 7.5 and OT was 57, PT was 79. On 4/4/22, bilirubin reduced to 3.2 and OT, PT were normal. And he was symptom-free during this period. His sputum CB-NAT showed MTB not detected. X-ray chest was within normal limit, which was done on 5/3/22. USG abdomen, which was done on 15/2/22, was multiple retroperitoneal lymphadenopathy, which size of which was 21 into 115 mm, with edematous gallbladder, which was suggestive of abdominal cox. On 14/9/22, we repeated his USG and it showed mild hepatomegaly with peripancreatic lymph nodes. On 5/12/22, his USG was absolutely normal. He is right now he is on TLD and along with CPT. His current viral growth, which was done on 23/5/23, is TLD, and CD4, which was done on 10/1/24, is 310. Thank you, ma'am.
Thank you. Thank you for sharing this case, and it's indeed a well worked up case. And what I understood was that there's no microbiological confirmation of TB in this case. No? It was based on the ultrasound of suggestive of tuberculosis.
And he
Okay.
was diagnosed in private hospital, and from there he was on ATT. So we continued on the same regime.
Okay. Okay. If anybody has any question from the case presenter, please kindly ask. You can kindly ask her. She has raised a very important question and of reintroduction of ATT. And so because everybody goes by their own school of thought in this, and there's still a lot of confusion there. So I think our expert wants to say something. Yes, sir.
So this is a very good case which has shown you that the timely intervention will save the life. And you have seen two things from this, that how we have managed the case. He has done very good management for the drug-induced hepatitis. And another thing you have seen that by giving ATT, the immunosuppression has improved. The CD4 count has increased. So we should start the ATT as early as possible when the patient is diagnosed to have HIV. Now, one important point here is that whenever we are starting a anti-tuberculosis treatment, in a case of abdominal tuberculosis, we should do some pre-treatment evaluation, like is there is any involvement of the liver or not in the abdominal tuberculosis. We can take the history of risk factor for development of the hepatitis, because these drugs, as you know, are hepatotoxic, like history of alcohol abuse, age, or patient is taking any other hepatotoxic drug, like ART has some hepatotoxic drugs patient is taking, or the patient has some disease like involvement of the liver, fatty liver is there, cirrhosis is there. So these things we can see from the ultrasound, and we can take the baseline liver function test. Because when the patient was detected here suffering from deranged LFT, the serum bilirubin was 5, which is a severe type of hepatitis. So that I will discuss in my lecture, that how will you define it is mild, moderate, and severe. So these things we can do whenever we get a patient with the abdominal tuberculosis. Baseline LFT is helpful if the patient has other risk factor of hepatitis. So in the management of hepatotoxicity with TB regime, first I will tell you what are the TB regimes which are available. The pulmonary tuberculosis is divided into two forms, or any tuberculosis is divided into two forms from management point of view, into a drug sensitive or a drug resistant TB. In a drug sensitive TB, we give fixed dose combination of 4 drugs, that is the INH, rifampicin, parazinamide, and ethambutol for 2 months, followed by 4 months of 3 drugs, INH, rifampicin, and ethambutol. And you have seen that I have labeled 3 drugs HRZ as red, because these 3 drugs are hepatotoxic. So we should keep in our mind whenever we are starting any treatment in any patient, that we are giving drugs which have potential to cause hepatotoxicity. So we should look for the risk factor for development of hepatotoxicity. Now coming to the resistant type of tuberculosis. In the resistant type of tuberculosis, we have at present three types of regime. One is for H monoresistant, which contains levofloxacin, rifampicin, ethambutol, and parazinamide. And you know, rifampicin and parazinamide are hepatotoxic. The second is the shorter MDR treatment regime, which contains bedaquiline, levofloxacin, ethinomide, clofazimine, parazinamide, high-dose INH, and ethambutol. And out of these, four drugs are hepatotoxic, that is bedaquiline, ethinomide, parazinamide, and INH. The third regime is the all-oral longer MDR-TB regime, which contains bedaquiline, levofloxacin, linezolid, clofazimine, and cycloserine, and bedaquiline is hepatotoxic among these drugs. Now, when a patient with the tuberculosis present with, he will either sometimes, in some cases, is a carrier of virus, like hepatitis B surface antigen is positive, or hepatitis C is there, or the other virus like HIV is also there in those patients who are co-infected, or the patient who have a history of acute hepatitis in the past, or who have history of excessive alcohol consumption. These are the patients who are at a high risk of development of hepatitis. So naturally our question is, can we give them these drugs? Yes, you can give them these TB regimes provided that there is no clinical evidence of chronic liver disease. So how we'll look for the chronic liver disease? That is by clinical examination and blood test. And so these things are very important when we are starting ATT in any patient. So hepatotoxic reaction to these drugs are more common in patients who are having advanced liver disease or where they have unstable liver disease. So we should do the liver function test to find out their status of the liver disease. If the liver disease is very severe, then the lesser hepatotoxic drugs have to be used. So how will you say that the liver disease is mild, moderate, or severe? That I will discuss in the subsequent slides. So clinical monitoring of all these patients. If you have started the ATT regime in these patients, then the clinical monitoring should be done at regular time so that you can detect these disease hepatitis if occur at the appropriate time and so that you can manage it. So these are the signs and symptoms of the chronic liver disease. In the symptoms, you have loss of appetite, fatigue, weakness, which are non-specific. Jaundice, if it is present, yes, it is there. Leg swelling, pedal edema, abdominal distension, maybe because of ascites, increased bleeding tendency because of the liver disease, history of family blood vomiters or history of passing black color stool, and then slow speech, confusion episodes which indicate the severe form of the liver disease. It may be because of the hepatic encephalopathy. Similarly, the signs are the muscle wasting, jaundice, ascites, stretch mark, or hepatomegaly, pedal edema, hepatosplenomegaly, and the presence of the blood vessel over the skin. Endoscopy findings may be there like esophageal varices, hyperpigmentation, and low blood sugar. These are the findings of chronic liver disease. So hepatotoxicity can be mild, moderate, severe, and potentially threatened. Now, in this case, you have seen that the total bilirubin is more than the ALT, SGOT, and SGOT levels were more than 5 times. In this case, it was around 434 to 432, and 40 is usually the upper limit. So you see that in the case which is presented now, the serum bilirubin was 5. So it is a severe form of the hepatitis. Similarly, bilirubin is also there. Depending upon the bilirubin, if it is more than 2, then it may become severe form of the hepatitis. Alkaline phosphatase, if it is more than 5 times of the upper limit, then it becomes a severe form. So in the severe and potentially threatened, we have to stop all the hepatotoxic drugs. And in the moderate, we can give these drugs with the monitoring depending upon case to case and considering all the LFTs levels, whether they are at what level. So that I will discuss in the next slides. So some amylase and lipase are also important. So in some cases, all these liver function tests are normal and amylase may be elevated. In those cases, if we take the consultation of the gastroenterologist, they will do the fibroscan to give the clearance. Sometimes we find the disease is there, which is a chronic liver disease, where the liver functions are normal, but they are compromised. So there you can use the TB regime, but with the monitoring. So when there is a pre-existing disease, one should be very careful for using the hepatotoxic drugs so that we should prevent these drug-induced hepatitis. There are three types of the hepatotoxic. These regimes are available, which we can use in the pre-existing liver disease. A regime containing two hepatotoxic drugs, like instead of RHZD, we are using only HRE. This is for 9 months, and another regime is the FHR, where you use streptomycin, INH, and rifampicin along with H and R in the continuation phase for 7 months. And third is the rifampicin, parazinamide, and ethambutol. So these are the drugs which can be used in pre-existing liver disease, where the two drugs are used. In which case, in the mild, moderate, or severe, we have to use this. I will discuss in later slide. Next, we have the regimes where only one hepatotoxic drug is there, like SHE. This is the standard regime before the rifampicin has invented. So this is the SHE for 2 months or 3 months you can give, followed by INH and ethambutol. Here the H is the only hepatotoxic drug. Third is the regime where there is no hepatotoxic drug, which we usually use when the patient develops drug-induced hepatitis. And this regime consists of streptomycin, levofloxacin, and ethambutol for 18 to 24 months. Since it has no INH, no rifampicin, so it has to be given for 2 months, 2 years, 1.5 years to 2 years. And in these patients with the pre-existing liver disease, you have to do the clinical monitoring and the liver function test if possible in all patients with the pre-existing liver disease. So when to give these regimes in the patient with pre-existing liver disease depends upon their liver function test and their clinical examination. We have this child-put score in which we may look for the bilirubin, albumin, and the INR, ascites, and the encephalopathy. If the bilirubin is less than 2 milligram, it is score 1. If it is between 2 to 3, it is score 2. And if it is more than 3, it is score 3. So like in our case, the score was 3 in the bilirubin. If we have the value for the albumin, or if we have the look for the ascites, because they said there is abdominal distension, but the ascites I don't think was present. If it is a moderate, then it is score 3. So for all these, we will add their score. And if the score is 1:6, then it is a mild form. Like if the patient has cirrhosis, but the score is 1:6, in that case, you can give these regime with the two hepatotoxic drugs like HRE or SHR. If the score is between 7 to 10, then you can use the regime with one hepatotoxic drug like we have SHR followed by SHE followed by HE. That regime can be used when there is a one score is 7 to 10. If the score is more than 10, 11 to 15, then you have to use these regimes which do not contain any hepatotoxic drug like streptomycin, levofloxacin, and fluoroquinolone. Fluoroquinolone, streptomycin, and ethambutol. In cases of acute hepatitis, you should not use any regime. You should stop all these drugs and then you should wait for the enzymes to come to the normal. And in a severe case where you think that the ATT is necessary, you can start with the regime which is non-hepatotoxic without any hepatotoxic drug, zero hepatotoxic drug like streptomycin, levofloxacin, and ethambutol. So if the patient has a pre-existing liver disease and if we have to use the he has H resistant, then you are using the H monopoly drug resistant TB regime. In this regime, which drug is hepatotoxic? In this regime, rifampicin is hepatotoxic. So we, and parazinamide is hepatotoxic. So we can look for those patients if they have any pre-existing liver disease, like history of alcohol abuse, like pre-existing history of any acute liver disease like jaundice in the past, or if they have any history of hepatitis B or hepatitis C infection. And if there is no clinical evidence in these patients with the pre-existing liver disease and the liver functions are abnormal, other etiology should be looked. If they are not there, then you can start the ATT. Otherwise, you have to switch over to the other regimes. So, like if the patient is very sick, in that case, I have told you, you can use a 3 non-hepatotoxic medication with the one injectable drug, fluoroquinolone and cycloserine. If the patient is not seriously ill, one can wait for the introduction of the ATT till the liver enzymes comes to normal or near normal. If the enzymes are more than 5 times the upper limit of the normal on the before starting the ATT, then you cannot give the hepatotoxic drugs. You can start with the non-hepatotoxic regime consisting of one injectable, fluoroquinolone, and cycloserine if the patient has pre-existing liver disease. In a patient with a pre-existing liver disease where you have a RIF resistance or MDR and you are planning to give shorter MDR regime, you see that there are 4 drugs which are hepatotoxic. So in these patients with pre-existing liver disease with persistently abnormal liver function, so if the patient has pre-existing liver disease and they have mild disease, as I have told you with the child score, you can see and classify the severity of the disease. If the liver functions are within normal limit, then you can start with the shorter MDR regime with the monitoring of the liver function test. But in patient with pre-existing liver disease and the persistently abnormal liver function, one should not use the shorter oral MDR regime and one should look for the alternative regime. And in these cases, we will recommend the all oral MDR regime. So all oral MDR regime, if we see that there is only one drug which is hepatotoxic, that is the bedaquiline. So we do the pre-treatment evaluation. If the hepatitis enzymes are raised, if the liver function tests are abnormal, we evaluate the patient for the various, like whether the patient has pre-existing liver disease, reason for it, hepatitis B, hepatitis C, alcohol abuse, or cirrhosis. Accordingly, we look for the liver function test. If the liver function tests are normal, we can start this regime with the monitoring. And if the liver function shows you that they are abnormal, then you have to look for the substitute of the bedaquiline from the replacement sequence, which is delamnide or one amikacin injectable. So accordingly, you have to modify the regime in these patients. Now, hepatotoxicity is during the treatment of TB regime. You have advised a TB regime to the patient, and patient on baseline has a normal, within normal limit of the liver function test. Patient has pre-existing liver disease, may have or may not have. So in these cases, we have to advise the patient that these drugs have hepatotoxic potential. So they should look for the sign and symptoms. And the sign and symptoms of the hepatitis are nausea, vomiting, yellow discoloration of the sclera, and these are the common symptoms, weakness and fatigue, as I have told you about these symptoms in the beginning. So you will advise them the liver function test, and on based on the liver function test, the hepatitis will be defined as if the enzymes level are more than 3 times the normal in a symptomatic patient. If the enzymes are more than 5 times, then the normal without the symptoms also, then you have to consider for the hepatitis. And if the enzymes are raised more than 3 times and the bilirubin is also raised more than 2 times, then it is also a hepatitis. Even though there are no other symptoms like nausea, vomiting may not be there, even then it is a hepatitis. So in the management, you should stop all these drugs which are hepatotoxic and then wait for 7 to 10 days before starting the ATT. When the symptoms resolves and when the enzymes level reduce and minimum it should come less than 2 times the upper limit of the normal, then you can reintroduce these drugs. And if the patient is very serious and you think that the anti-tuberculosis treatment is required, as in our case where they have given this three non-hepatotoxic drugs like streptomycin, ethambutol, and fluoroquinolone like levofloxacin, you can start and you can introduce. Now, whenever there is a jaundice, patient is on ATT, we should suspect these drugs. Like I have told you that in the drug sensitive TB patient, so look whether the patient is taking which regime. If he is taking drug sensitive TB, then most likely three drugs Z, H, and R may be responsible. If he is taking or she is taking drug resistant TB treatment, then these drugs like for Ethio, PAS, Bitocline, they are responsible. Sometimes you are using in these patients Z also, H also, and R also in shorter regime. You are using in H monoresistant regime R. So these are the drugs you should suspect depending upon the type of the drug resistant TB regime. Whether it is a mono H resistant or it is a shorter MDR regime or it is a all oral MDR regime. I have discussed these drugs, so I will repeat it again also in next slide. And you should also know what are the risk factor. Take the history if the patient has history of alcohol abuse, if the patient is elderly, more likely to develop these disease. So more monitoring is required. If the patient says that he has nausea, vomiting, then it is more likely that he may have hepatotoxicity. And there is no jaundice, but you should do the LFT. So first thing is to stop all hepatic drugs. If there is an increase in the liver enzymes ALT, SGPT or STOT more than 5 times of the upper limit. So we take 40 is the upper limit. So if it is more than 200, then definitely you should stop all the hepatotoxic drug. And if it is more than 3 times of the upper limit, like if it is 120 plus serum bilirubin is 2.53, you should stop these drugs. Or if the enzymes are more than 3 times, but the bilirubin is less than 2 times, but patient is symptomatic, even then you should stop the treatment. Then don't wait that these enzymes should reach up to 5 times. Because you have seen in the last case, the patient on the subsequent visits has a more increase of the bilirubin and the enzymes, but at the last there is a decrease in the enzymes. So basically it is a hepatocellular jaundice drug induced. There is an increase in the enzymes and bilirubin excretion takes some time. So the recovery, with the recovery of the liver, when you stop these drugs, the enzyme will start falling, and after that, when they become decreased, then the bilirubin start decreasing. So it will take more time for bilirubin to become normal. So monitoring of these enzymes and bilirubin should be done according to the patient conditions. And once the enzymes improves, and then we should consider the reintroduction of these drugs, starting from the least hepatotoxic agent first and monitoring the liver function along with it. So for various regime, I will discuss the sequence, how to start the anti-TB drugs in all the 5 regimes. If OTPT do not return to baseline after stopping these drugs or after giving these 3 drugs regimes, or it keep on increasing, then we should look for the other causes like the viral hepatitis or the alcohol hepatitis or some other non-TB drugs which can cause these hepatitis. So To rule out other causes of hepatitis is important. One should not start the treatment, restart the treatment till the symptoms subside and the enzymes returns to baseline. And if the liver enzymes cannot be performed in the periphery, then one should wait for 2 weeks after the jaundice has disappeared to restart the treatment. Once the jaundice disappear, enzymes has become normal, one can restart the treatment with one drug at a time, starting with anti-TB drugs from the safest drug like rifampicin, INH, parazinamide. So I will discuss for the other drugs also, drug resistant, the sequence also. And here there are two school of thoughts. One gives all these drugs together, or one gives in the sequence in the lower doses that I will discuss. The schedule I will discuss in the next few slides. So in patients with severe disease in whom treatment cannot be stopped, we can always consider non-hepatic regimes consisting of one injectable and like streptomycin or amikacin and one fluoroquinolone, levofloxacin, ethambutol. So, like reintroduction of the ATT, this is the ICMR guidelines. They say that reintroduce only if the enzymes are less than 2 times of the upper limit and normal bilirubin. Start one drug at a time, help identify the culprit. So this is the advantage when you start one by one, it will help. But there are two schools. One says that give all these drugs, the most of the patient will tolerate it. And if they again redevelop it, then you can start one by one, and then you can identify these drugs. So, but this is the another some guidelines. They say that you start with this type of the rescheduling. Start one drug at a time. Help identify the culprit. Rifampicin may be introduced at a 10 milligram per kilogram dose. After 1 week, add isoniazid 5 milligram per kilogram if LFT is normal. After 1 week, add parazinamide 25 milligram per kilogram if LFT is normal. If anti-tuberculosis therapy, hepatitis, severe, like liver failure, or if there is a coagulopathy or altered sensorium, I have told you that you can determine by using the child scoring. If it is severe, means more than 10 score is there, then paracetamol reintroduction may be avoided because it is considered to be most hepatotoxic drug. Another approach, as I have told you, to start with the low dose of one drug followed by full dose after 3 days. So duration of ATT is count only when full ATT is started. So the full when the full treatment is started, from that you should consider the duration of ATT. So like these are the two schools, and this is one is the sequential where you start one drug like rifampicin 10 milligram per kilogram body weight, wait for a week if and repeat the LFT, then you give the isoniazid 5 milligram per kilogram full dose, and then wait for a week and then repeat the LFT and start with parazinamide. Another where you can start the incremental dose, initiate with the 150 milligram per day in an adult rifampicin and gradually increase say 300 milligram and 450 milligram and 600 milligram in next 4 days, and then you initiate the ISO, and every time you monitor the liver function test, and after 3 days to 4 days, and if they are abnormal, then you can stop these drugs. If they are normal, you can continue with it. Then you can initiate the second drug, that is the isoniazid. So the order of addition of drugs are rifampicin, followed by isoniazid, and then followed by parazinamide. So in the isoniazid, you can start with a small dose of 50 or 100 milligram per day. Next day, you can go for the another increase to 200 milligram, followed by 300 milligram, and then after that, you can initiate the parazinamide starting from 250 milligram to 500 milligram and increasing in an incremental dose. Well, every time when you change the increase the dose, like say 750 milligram parazinamide at that time after 3 to 4 days, you do the liver function test. And if the liver function test increases in the same order like we have discussed, If without any symptoms, it is more than 5 times of the upper limit, you have to stop it. If it is increased bilirubin more than 3 times, then you have to stop it. If the patient develops symptoms and then three more than 3 times, you can stop these drugs. Otherwise, you can continue these drugs. So it is a summary like in a patient how to initiate. Like ethambutol is a non-hepatotoxic drug. You start with full dose of ethambutol plus start with 150 milligram of rifampicin. Then you can add rifampicin 300 milligram, 450 milligram, and 600 milligram. And then you add INH like 100 milligram along with rifampicin and ethambutol. Then increase the dose of 100 milligram to 200 milligram and to 300 milligram. And if the patient remain asymptomatic, only then you should increase it. If he is symptomatic, then you first do the LFT and interpret the LFT as I have told you. Then finally you will add the parazinamide starting with 250 milligram, 500 milligram, and 750. Once the patient will tolerate all these medicines, then you can continue the treatment, and the duration of the treatment will be considered from that day only. And if the patient has taken these non-hepatotoxic drugs, is also taking regime like streptomycin, then you can, if the patient is tolerating well and enzymes are there, look for a week and repeat the LFT, and then you can omit these or withdraw those drugs also, like streptomycin, ethambutol, and levofloxacin. I think this is one of the questions she has asked today in the presentation. Now, in the drug sensitive TB, as I have told you, again I will repeat, if the enzymes level are more than 5 times of the upper limit with normal bilirubin, even in a patient who is not symptomatic, then you continue. If the enzymes are less than 5 times, then there is no symptoms with normal bilirubin, then you can continue with all the drugs, monitor the liver function test and the symptoms, and continue with all the drugs. If the patient has enzymes which are more than 5 times of the upper limit with normal bilirubin, or the enzymes are more than 3 times and bilirubin is also raised, or enzymes are more than 3 times and the patient is symptomatic, then first step is stop these and hepatotoxic drugs. In drug sensitive TB, these are the 3 drugs which you can stop. So you will not give ethambutol alone, so stop the ATT. Then monitor the clinical symptoms, repeat the bilirubin enzymes after a week, and then when they become normal, and on the left hand side, when you are continuing the treatment, if the patient symptoms are continuing, then you repeat the LFT, and in any stage, if the enzymes are found to be raised more than 5 times, or the bilirubin is increased more than 2 times, or the patient has raised enzymes and he is symptomatic, again you have to withhold these medicines. Once these medicines were involved, you manage the patient by looking for the symptomatic improvement and by monitoring the liver function test. And if the patient is very sick, you can add the non-hepatotoxic regime. Once the enzymes has come to normal, then you can reintroduce first the rifampicin. I have told you how to increase. Start with 150, repeat LFT after 3 to 5 days, and then you can give 300 milligram full dose. So depending upon the patient and the availability, you can do this. So for INH, you can start with 50 milligram, increase from 100 milligram, 200 milligram, then 300 milligram, monitor with LFT, similar for parazinamide. So initial dose, these are the basically BTS guidelines, which also recommend accordingly. So these are the doses, how we can go with. So they have recommended the INH should be introduced initially at a dose of 50 milligram, increasing to 300 milligram sequentially after 2 to 3 days, if no reaction occur, and then continue. Similarly, after 2 to 3 days with reaction to INH, rifampicin to be started at 75 milligram per day and can be adding increasing to 300 milligram. So similar thing which the NTP has, and as I have told you. So in a H monopoly resistance, again the same principle are followed. If the enzymes are more than 5 times or more than 3 times with bilirubin increase more than 2 times or with symptoms, you have to stop these two drugs, monitor their enzymes and bilirubin, and then anytime if on the other side, if they have deterioration of the liver function test, you have to stop these drugs. And then you can uh, monitor these patients with LFT, and then if the patient improves, then you can start the reintroduction of these drugs when the enzymes has come to less than 2 times of the upper limit, and then you can introduce these drugs as I have told you. And if there is no improvement, then we can continue to hold these drugs, and we can replace rifampicin or parazinamide, which is responsible, and we can substitute that drug with some other drugs. And when we will replace these drugs with any other drug, then the treatment has to be extended for 9 months. Even the patient has good bacteriological response at 5 months. Like if Z cannot be given, you can replace with the linezolid. If linezolid cannot be given, you can replace with clofazimine and cycloserine. This is also available in the NTP training module, which you can refer. Here, all these patients has to be treated for 9 months instead of 6 months. If rifampicin cannot be used, then you have to switch over to the other appropriate regime, which can be a all over longer regime, because shorter regime for MDR, as I have told you, is not suitable for the patient who has hepatotoxicity or chronic liver disease, where there is a abnormal enzymes are always there. So shorter MDR, I have told you that these are the drugs which are bedaquiline, ethinomide, and parazinamide and INH, which are hepatotoxic. If you detect the hepatotoxicity, the principle is same. You have to monitor the enzymes. If the enzymes are more than 5 times of the upper limit, stop these drugs. If the enzymes are more than 3 times of the upper limit with the symptoms, stop the drug. If the enzymes are more than 3 times of the upper limit with the increased bilirubin more than 2, stop the drug. If the enzymes are up to 3 times or more than 3 times, but less than 5 times, and no symptoms, then you can continue these drugs with the monitoring. And anytime during the monitoring, if you find that the conditions are there to stop the drug, you have to stop these drugs. So if the patient is improving after continuing these drugs, then you can continue the treatment. If the drugs has been withheld, if the patient is have conditions I have told you in which you have to withhold the drugs, so you have to withhold all these drugs. The shorter regime, 4 drugs, means you have to withhold the entire regime basically and monitor the symptoms and the LFT. If the LFT returns to the normal level where you can start the treatment and there is a clinical improvement, then you can start the treatment one by reintroducing. I will tell you the order in next slide. Or if the patient cannot improve then or deteriorate, then you have to shift to the other regime. So the reintroduction in the shorter MDR is so first drug you will add is bedaquiline if the patient enzymes become normal. After bedaquiline, you will add which drug? INH. After INH, which is parazinamide. This is to be added in the incremental doses as I have explained for the drug sensitivity. Then you can add parazinamide and then in the end you can add ethinomide. Similarly, for the all oral regime, only bedaquiline is a hepatotoxic, so it is the least hepatotoxic regime. Here, if there is a need to stop the drug and the reintroduction is required, then this is the schedule. First, you add bedaquiline, then again, you will not add H because we don't have H here. You add parazinamide, and then after parazinamide, you add ethinomide, and after ethinomide, pass. Though these drugs, parazinamide, ethinomide, are not the part of the all oral longer regime, but I have mentioned here because sometimes you have to modify the all oral longer regime by the replacement sequence depending upon the drug resistant pattern or other conditions. So that's why I have discussed here. So do not restart treatment till symptoms resolve and liver enzymes return to baseline. This is the in nutshell. If liver enzymes cannot be performed, wait for 2 weeks after jaundice has disappeared to restart the treatment. Restart the treatment with one drug at a time, starting with rifampicin, INH, and paracetamol. This is the order of reintroduction. Right. Right means R rifampicin, I INH, P is paracetamol. E you will start with the beginning. This is to remember mnemonics to remember how to introduce. Like for cutaneous reactions, you start with H first. HRZE there. For drug-resistant TB regime, BDQ is the least toxic, so at first, then followed again the same HZ, ETO, and PAS. In patients with severe disease in whom treatment cannot be stopped, use a non-hepatotoxic regime. And I have told you in the pre-treatment liver disease how to manage the mild, moderate, and severe. Depending upon you can use the various non-hepatotoxic regime in the cases of drug-sensitive TB, or in cases of MDR, you have only these streptomycin, levofloxacin, and cycloserine, which you can use. Thank you very much. If you have any question, I would like to answer.
Thank you, sir. Thank you for such a making things so crystal clear to us. Actually, sir has covered all the practical points and all the points from the guidelines. So it's going to remain a very important resource for us because we'll be posting this, sir, on our e-NISCHIT website. So whenever we have case-to-case problems, we can go back to this presentation and learn from it. And according to our case, we can refer back. So thank you, sir, for giving us such an important, excellent diadetic. I would like to request Dr. Archana, has your queries been resolved now?
Yes, ma'am, but one question is there that in the situation where streptomycin is not available always, then can we start the treatment with linezolid? Linezolid.
You have to see now if you are using the drug sensitive TB, then in the drug sensitive TB, the non-hepatotoxic drugs usually we have taken, but yes, if it is very urgent, if you are not getting the aminoglycosides, then naturally you can use the linezolid because it is a non-hepatotoxic drug. Yes, cycloserine you can add cycloserine, levofloxacin, ethambutol, and this. But from group A, yes, you can use it. But that should be the exception to the rule. It should not be the rule.
It's very difficult for the patient to come within 3 days because they come from very far places. So repeat LFT is not possible. Then the steps which we had started, is it okay or we should?
Like for drug sensitive TB, I will say that it is okay if the patient is coming from far away, means the facilities of LFT is not available. Patient is means not very sick, not hospitalized. In that case, you can wait, and when the liver, when your jaundice has disappeared, after 2 weeks, you can start the treatment, and you can start with the entire treatment together also, because there are two thoughts. One is that you can tell that you start with rifampicin 1 day, paracetamol. These 1 day, if you do not have symptoms, they can continue with that medicines after 2 weeks. But if the patient is hospitalized, like in a drug-sensitive TB, then this is the method. But in the field, yes, it is no jaundice is there, only vomiting is there, and you have done the, then you can, but for jaundice, if it is there, you have to stop this medicine. If the patient is all right, no vomiting is there, then you can observe the patient. Once the jaundice has disappeared, you can start these medicines.
Thank you, sir.
After 2 weeks.
Thank you, sir. And thank you very much. It was great presentation. Thank you, sir.
So our first question was, which is the following sequence is recommended for reintroduction of TB drug in management of drug-induced hepatitis by LTEP line? So the correct answer is A, bedaquiline, isoniazid, pyrazinamide, ethionamide, and pass. So the question 2 was hepatotoxic drug should be stopped in all of the following conditions except. So the correct answer is option D, AST or ALT elevations lesser than 3 times of the upper normal limit with normal bilirubin and symptomatic patients.
Rajesh, so what do you think? I would like to know from you, Ki, because it's such a common and but still a very great problem. So, आपको लगता है कि in your experiences you lose people because in ARD center we have this problem that we don't have the admission facility. So if the patient is having side effects, most of the time
That's what sir has explained very well. Just like our institute is tertiary center, so we can test all the patients like LFT, bilirubin and liver enzyme and all. But in primary health center, somewhere maybe some facilities are not there, so you cannot test liver function test directly. So you can only see if some jaundice is there in the patient. So liver enzymes will be not available there. So you can just wait for jaundice to subside for 2 weeks and then you can start the treatments.
So any take-home messages you want to say before we conclude the session?
So whenever you are starting the anti-tuberculosis treatment, because when the patient is having a drug-resistant TB, then it is like everybody knows we have to do the pre-treatment evaluation. So though whenever we start the treatment, it is a part of taking history, past history of any disease, past history of any personal history of any drug abuse, any alcohol abuse or smoking. But for TB treatment, whether it is a drug sensitive TB, we should do the pre-treatment evaluation and look for the liver diseases in particular, because all our these drugs, which are important drug in the drug sensitive TB, that is rifampicin, INHF, pyrazinamide, these all three drugs have a potential hepatotoxic effect. So we should not tell the patient that this is a very hepatotoxic, and we should tell this patient, give the message that sometimes the patient may develop gastritis, may he feel stomach ache, or he will have vomiting, he will have a nausea. So if the nausea, vomiting will not subside and it is persistent, then he should come back and you should look for the sclera of the patient. If the sclera of the patient is a yellow, then immediately you should stop the medicine before that anybody else to tell the patient to stop the medicine. So it is important to see the sclera of the patient, eyes white, which is this is the sclera white. Doctors are there mainly here. They should tell the health worker. In fact, they should give this message to their health worker, because the health workers are now monitoring this patient at the periphery. So these message should be there with the health worker. They should look for the sclera in the beginning also. Sometimes the patient has jaundice and he will come to us, and at a spinal level we can prescribe the ATT also. So we should develop a habits of the health worker that any vomiting and these things, they are not simple gastritis, they can be jaundice. So they can look for this sclera. If the sclera is yellow, it should be stopped immediately. There is no need to do the LFT to diagnose a jaundice. When the jaundice is more than, bilirubin is more than 2 gram, in the open sunlight, if you see the patient, then you will see the yellow color, yellow tinge of the sclera. So that is most important. History of alcohol abuse should be taken, and those who have habit of taking the alcohol, they should be told that these can interfere with his treatment. If he will develop the problem, liver problem due to these alcohol, then the drugs have to be stopped, and then the TB treatment will be interrupted, and then his cure will become difficult. So this is very important. Then if any patient has a history of alcohol, he should be evaluated for the chronic liver disease like cirrhosis. We should ask simple question if he had any swelling of the feet, if they look for the ascites by examination of the abdomen, and you can look for the chronic liver failure signs like there is a decrease in the hairs in the armpits, chest, or there are spider nevi are there on the skin. So these are the physical examination sign which as a medical officer or as a doctor we should do it and look for these signs. If they are there, then their risk of developing hepatotoxicity is very high. Then there is need to do the in liver function test in the beginning, so that we should have their baseline whether the liver function tests are normal or abnormal. If they have normal compensated liver function test, you can start these drugs. But if they are abnormal, then you have to think whether they are more than 5 times. In that case, you have to look for the non-hepatotoxic regimes. So that is very important. In this way, we can prevent most of these reactions also.
So now we have come to an end of the session. So I would like to thank our case expert today, Dr. Puri. Thank you, sir, for the excellent presentation and answering all the questions. I hope the questions are answered. And I thank Dr. Rajesh for sharing his experience. I thank Dr. Ananya for moderating the session. I thank Dr. Archana for bringing up such an interesting case. And at the last, I would like to thank all our participants who make the show successful by their attendance. और मैं सभी पार्टिसिपेंट से अनुरोध करूंगी कि वो इसी तरह के या और अच्छे इंटरेस्टिंग केसेस लेकर आए ताकि हम वो डिस्कस कर सकें और क्रॉस लर्निंग हो सके. So I thank my team member and I thank you all. Thank you. धन्यवाद.
Thank you.